Leah കേൾക്കാമോ?
കേൾക്കാം.
എന്തോ ചെറിയൊരു പ്രശ്നം ഉണ്ടായിരുന്നു, വർക്ക് ചെയ്യുന്നുണ്ടായിരുന്നില്ല മൈക്രോഫോൺ.
സ്റ്റാർട്ട് ചെയ്യാം.
സ്റ്റാർട്ട് ചെയ്യാം. So yesterday we have discussed about diabetic retinopathy and central retinal vein occlusion. പ്രശ്നമൊന്നുമില്ലല്ലോ അല്ലേ? ശരിക്കും കേൾക്കുന്നുണ്ടല്ലോ?
ഇല്ല മാം, കേൾക്കാം നല്ലോലെ.
ഓക്കെ, കാണുന്നുണ്ടല്ലോ അല്ലേ സ്ക്രീനും?
കാണാം.
So today we discuss some few small topics that can be asked as a short note only. So this is one is Eales disease. Eales disease is otherwise. Yesterday we discussed about two very important topics which can be either asked as an essay, like a sudden loss of vision, central retinal vein occlusion, and a diabetic retinopathy. Diabetic retinopathy can be asked as a short note or a fundus draw, fundus picture, like that. So this one can ask as maybe a small 2-mark question, or the causes of Retinopathy or tractional detachment, like that. So Periphlebitis retinae, or otherwise called as an Eales disease, it occurs as the name suggests. Phlebitis means inflammation of the vessel venous walls of the retina. That is, periphlebitis means the peripheral retinal veins are affected. Usually it occurs in young males and produces obstruction. This vasculitis produces venous obstruction, and whenever, as I explained, whenever there is a venous stasis or occlusion, there occurs ischemia of the retina. Whenever there is ischemia, that can lead on to hypoxia of the retina. This is a sequence of events: hypoxia of the retina, and the hypoxic retina produces vascular endothelial growth factor, leading on to neovascularization of the fundus. And neovascularization of the fundus this new vessels behaves differently from the normal retinal blood vessels because they lack all the 3 vessel wall. Unlike the normal vessel wall, this has got only a single layer, which leads on to easy bleeding. And also this attracts, the new vessels will attract fibrous tissue or fibrovascular proliferation. And this fibrovascular proliferation contracts, which pulls the retina away from the underlying retinal pigment epithelium, leading on to tractional retinal detachment. So any patient who suffers from a venous obstruction or an arterial obstruction, it is not common with arterial. That is, neovascularization is not common with the arterial circulation because arterial obstruction lead on to anoxia. But venous stasis or venous obstruction leads on to hypoxia. So whenever there is hypoxia, hypoxic retina produces vascular endothelial growth factor struggling to strive or to produce blood vessels. And these blood vessels, which are formed in the life, during adult life, are abnormal blood vessels or new vessels. And new vessels, as I told you, has got a tendency to bleed easily and attract fibrous tissue, leading on to fibrovascular proliferation, pulling of the retina from the underlying retinal pigment epithelium, leading on to tractional retina. So any condition that produces retinal hypoxia is cause for tractional retinal detachment, vitreous hemorrhage, rubeosis iridis, and neovascular glaucoma. So one condition, such condition is an Eales disease. So there occurs bilateral occlusive peripheral periphlebitis and neovascularization. And the etiology, it is thought to be a hypersensitivity to tuberculous protein. So the patients, if presents with the features of Eales disease, you have to rule out underlying tuberculosis. Patient, as I told you, because of the fine blood vessels formation, new vessels that bleeds easily, patient presents with a recurrent blurring of vision in both eyes sequentially, one eye at a time and later the other eye. And if you see, you can see retinal occlusive vasculitis in the periphery of the retina with a new vessel formation. So it is cause for a recurrent vitreous hemorrhage. So you can get causes of question like causes of vitreous hemorrhage. So you can write Eales disease. And the complications like retinal tractional type of retinal detachment, rubeosis iridis, neovascular glaucoma, and cataract. The treatment is treat the underlying condition. If the patient has got a tuberculosis, you have to treat the tuberculosis. And vasculitis, that is inflammation of the retinal venous walls, you have to treat with the steroids. And if neovascularization occurs, as already mentioned during the treatment of diabetic retinopathy, any condition that produces retinal neovascularization, the treatment is pan-retinal photocoagulation, laser PRP. And if there is a tractional retinal detachment and persistent vitreous hemorrhage, you have to treat with the vitreous surgery, pars plana vitrectomy, and retinal detachment surgery. So this is the picture of Eales disease. You can see the veins are, you cannot see any blood column in the veins beyond the obstruction. You can see the veins appears white in color. Okay, all these blood vessels are sheathed. Sheathed means because of the perivascular inflammation, there is a fibrosis along the vessel wall leading on to sheathing of the blood vessels. And you can see there are extensive retinal neovascularization and the whole retina is detached. The white area is the detached retina. So that is one small topic, Eales disease, leading on to young males, occurring in young males, leading on to recurrent vitreous hemorrhage, tractional retinal detachment, secondary open angle type or angle closure type of neovascular glaucoma. This is another small topic, that is a persistent hyperplastic primary vitreous. Initially, it is called as a PHPV. The new term used is persistent fetal vasculature. So the blood supply in the intrauterine life is persisting in the adult life. That is called persistent fetal vasculature or persistent hyperplastic primary vitreous. But the new name is PFV. So it can occur either in the anterior aspect just behind the lens or at the retinal level. Usually it is a cause for a white pupillary reflex. White pupillary reflex, you can get a question on white pupillary reflex, which is otherwise called as a amarotic cat's eye reflex. AMAUROTIC, amarotic cat's eye. Cat's eye reflex. It is called amarotic cat's eye reflex or white pupillary reflex. There are so many conditions in which the child can present with a white reflex from the pupillary area. The commonest reason, as you know, is a congenital cataract. Other causes, the most important and the dangerous cause for amarotic cat's eye reflex is retinoblastoma, the tumor with a retinal detachment, underlying retinal detachment can lead on to white reflex from the pupillary area, that is called amarotic cat's eye reflex. So the differential, all conditions of amarotic cat's eye reflex, the first and foremost is retinoblastoma, and the differential diagnosis of retinoblastoma, or otherwise known as a pseudoglioma. Initially, retinoblastoma was called as a glioma of the retina. It is a misnomer, and all the conditions that mimic retinoblastoma is called pseudoglioma. So, persistent fetal vasculature is a condition that can lead on to a white pupillary reflex from the pupillary area, white reflex from the pupillary area. It occurs in full-term infant in comparison with a retinopathy of prematurity, which is another condition that can lead on to white reflex from the pupillary area because of the tractional retinal detachment. And in contrast to the retinopathy of prematurity, which occurs in premature infants, this occurs in a full-term infant and it is unilateral. The other one, that is retinopathy of prematurity, is bilateral. And patient can have cataract, neovascular glaucoma, and sometimes microphthalmos. Another condition that can lead on to a retinopathy, white reflex in the pupillary area, is retinopathy of prematurity. I included this topic because in a few years back, this was asked as a 3-mark question. So retinopathy of prematurity, initially it was called as a retrolendal fibromatosis. So late stages of retinopathy of prematurity, the whole retina is detached and it comes just behind, the whole retina comes just behind the clear lens, and it looks like some fibrous mass just behind the lens. So that is why it is called as a retrolendal fibromatosis. That is a differential diagnosis of retinoblastoma. As I told you, it occurs in premature babies less than 32 weeks of age at birth with a low birth weight less than 1.5 kg. So the most common risk factor is prematurity, baby born with a gestational age of less than 32 weeks and a low birth weight. Even if the birth weight is normal and baby is preterm, or even if the baby is 34 or 36 weeks, but birth weight is less, with the other comorbidities like septicemia, oxygen, hyperbaric oxygen supply, all these can lead on to. So any infants less than 32 weeks or less than 1.5, or babies more than 32 weeks or more than 1.5 with a high risk features, that is in the postnatal period suffering from hypoxia or septicemia, all are prone for retinopathy of prematurity. So it is a proliferative retinopathy which occurs in 1.5 kg less babies less than 32 weeks with a high oxygen environment in the neonatal ICU. That is a bilateral condition. So what is the pathogenesis of retinopathy of prematurity? Normally, the retinal blood vessels reach the nasal retinal periphery by 8th month of gestation. Okay, so by 8th month, the whole nasal retina is vascularized. But the temporal retina reaches complete vascularization 1 month after birth. So this is a diagrammatic representation. This is an optic disc. This is the nasal retina. This is the temporal retina. So the temporal retina, the area is large, and hence by 8th month, it is the whole nasal retina is vascularized, but the temporal retina is by 8th month only up to this, and 1 month after, that is 9 months, is our normal gestation, and after 1 month of normal complete gestational week, the baby develops complete vascularization in the temporal retinal periphery. So this immature temporal retinal vessels are susceptible for high oxygen concentration. So the nascent oxygen, which is toxic to the retinal blood vessels, and this nascent oxygen will produce vasoconstriction. And whenever, as in the previous class and in the last topic I discussed, whenever there is a vasoconstriction, there occurs obliteration of the retinal arteries and veins, and again hypoxia leading on to neovascularization and tractional proliferation of fibrous tissue and tractional retinal detachment. So this is what I mentioned. This picture, you can see the pupil, there is a white color instead. That is by seeing with a direct ophthalmoscopy, indirect ophthalmoscopy, or 90D the appearance is a red reflex from the pupillar area. So whenever we shine the torchlight in the first class itself, I explained you, whenever we shine torchlight into the patient's pupil, it will fall on the patient's retina, and from the light gets reflected back to our eye, and we see the pupil as a red color. Any area or defect in the iris is seen as a red color. But instead of that red color, it is seen as a white color. And if you see carefully, you can see there are small, fine thread-like vessels. These are the retinal blood vessels. Can you see small vessels?
Yes, ma'am.
Okay, this is so this white color is not cataract. This is the normal clear lens, and behind the retina is crumpled with the blood vessels. So this is a retinal detachment. This this category of retinopathy of prematurity is what we call as retrolental fibromatosis. So I explained you that is a pseudoglioma differential diagnosis, or amaurotic cat's eye, or a pseudoglioma differential diagnosis of white reflex. Other causes include congenital cataract, persistent fetal vasculature. Eales disease is another condition. So there are 5 stages in retinopathy of prematurity. So this is the temporal retinal periphery, which is not vascularized. So in the first stage, you can see the normal retinal blood vessels that reaches only up to this area, and beyond this area, the vessels are abnormal. And you can see there is a demarcation line between the normal retina and the abnormal temporal retina. You cannot see any blood vessels in this area because this is not vascularized. The baby is born much earlier than that. Okay, so because of the oxygen supply or the neonatal ICU oxygenation, the patient developed some small vessels. So the first stage is a demarcation line with some abnormal blood vessels. Can you see this small crowded vessels? These are the abnormal blood vessels which demarcates the avascular retina from the normal retina. So that is a demarcation line, which is a stage 1. The stage 2, you can see instead of that line, it becomes a broad ridge-like, or it is slightly elevated with small vascular tuft between the normal vessel and the avascular normal retina and the avascular retina. So the line becomes a ridge, or it has got a 3-dimensional appearance. And in this third stage, you can see instead of the small the ridge, small blood vessels grow into the vitreous cavity. That is extraretinal fibrovascular tissue proliferation. This occurs almost 3 to 4 weeks after delivery. That is, if the baby is born at 31 weeks or 32 weeks, this occurs, that is stage 3 occurs by 3 to 4 weeks after delivery. So the baby's gestational age at that stage is only 36 weeks. That is 32 weeks intrauterine and 4 weeks after delivery. So only 36 weeks. So usually this occurs after 35 weeks of post-conception. And this again, these are abnormal blood vessels, and these abnormal blood vessels can lead on to hemorrhages into the retina and also into the vitreous cavity, leading on to retinal hemorrhage and retinal detachment. So in the fourth stage, that is a stage 4, you can see the retina starts detaching from the temporal periphery. You can see this ridge enlarges and the retina is, you have to have some imagination. So this area of the retina is detached. So this is a partial retinal detachment. So in the first 3 stages, there is no retinal detachment. And in the stage 3 and stage 4, there is a retinal detachment. So this is a diagrammatic representation. You can see the demarcation line, some fine new vessels in the retina. It demarcates the normal retina from the abnormal retina. This is the second stage, that is a stage 2 with a ridge with some abnormal dilated blood vessels. This is the stage 2, stage 3. You can see there is some ridge with some extraretinal neovascularization. That is neovascularization jutting into the vitreous cavity, which can lead on to vitreous hemorrhage and hemorrhages into the retina. This is the fourth stage. You can see this part of the retina is detached. This is the normal retina, which is pale pink in color, and this is the detached retina, which appears as a grayish white in color. Okay, the stage 5 is the total retinal detachment. This is the picture I showed you in the first slide. You can see the blood vessels in this picture very clearly. So these are the retinal blood vessels which is seen in a detached retina. So this stage is called as the retrolendal fibroplasia. Okay. So what is the importance? Importance is screening of all the babies born at before 32 weeks of age with a low birth weight. All babies with who are susceptible for this retinopathy of prematurity has to be screened for development of all these stages, and you have to treat at that stage itself to prevent further progression into stage 4 or 5, that is the retinal detachment, which needs surgery, and the surgery has got a very poor prognosis. So what is the treatment? So in any condition that is that produces retinal neovascularization, the treatment is retinal photocoagulation and also intravitreal pharmacotherapy, that is anti-VEGF injection. So of which the screening is the most important thing in patients with us. So if you have attended the OP, Mondays and Saturdays, we are conducting retinopathy of prematurity clinic. That is, the babies are sent from our pediatrics department and also from outside hospital to screen the babies to detect any retinopathy of prematurity. So all premature babies, you have to do an indirect ophthalmoscopy to see the periphery of the retina. So in the first class itself, I mentioned about the indirect ophthalmoscopy with a condensing lens plus 28 diopter, which is very essential for doing screening in patients with the retinopathy, suspected cases of retina. So RedCam is another instrument that can use to screen the babies in the periphery. If all babies, there is no need for, with the retinopathy of prematurity, there is no need for treatment. You have to follow them very closely. Only if it reaches stage 3 in or stage 2, that is several, that there is no need for you to understand all these terms. But anyway, there is no need for treating all the babies with the retinopathy of prematurity. In the early stages, we have to wait and see, because 80% patients, it can resolve by itself. But in 8% of the screen babies need treatment. And that 8% we have to detect, because if you are not treating this 8% of the babies, they will go into blindness. That is irreversible blindness. And ROP is nowadays a very, very important cause which comes under so many medico-legal cases. So the treatment is again laser photocoagulation, and if it progresses into retinal detachment stage, you have to do surgery, which has got a very, very poor prognosis. So this patient is a treated case of retinopathy of prematurity. You can see some black areas beyond the vascular retina. So this is the normal vascular retina. You can see this ridge-like structure with some hemorrhages, and you can see the laser burns here. So this is again another important cause for blindness in old age. So from the name itself, it is age-related macular degeneration. It occurs more than 65 years of age. So as age advances, the chance of getting age-related macular degeneration also increases. It is one of the leading cause of blindness in developed countries. Why developed countries? Because the life expectancy in developed countries is much more than in underdeveloped or developing countries. So this is the picture how a patient with a macular degeneration see an image. You can see since the central macular area is affected, the patient cannot see the central area, that is a central scotoma. So the risk factors include other than the age, the heredity, nutrition, smoking, hypertension, and ultraviolet rays. There are two types of age-related macular degeneration. One is a dry type, which is otherwise called an atrophic type, which can lead on to a painless, gradual loss of vision. And usually it is a cause for non-improvement of vision in patients who underwent cataract surgery. So age-related macular degeneration is dry type is a very important cause for non-improvement of the vision after cataract surgery because it is almost the same age-related macular degeneration and senile cataract. Both occurs more than 50, and this is especially more than 60 years of age. Another type is a wet or exudative type of age-related macular degeneration or AMD, which can lead to a sudden painless loss of vision. It can progress too fast. So the diagnosis is using indocyanine green angiogram, which helps you to visualize the choroidal vasculature. So in dry type of age-related macular degeneration, the treatment is multivitamins and antioxidants. And wet age-related macular degeneration, the treatment is photodynamic therapy, intravitreal anti-VEGF agents, and in advanced cases, some surgeries, submacular vitreoretinal surgeries. So this is the appearance of a dry type of age-related macular degeneration. You can see the normal normal optic disc, normal retinal blood vessels, and this is the area of the macula or the posterior pole. And in the posterior pole, you can see some whitish lesions. These are called Drusens. So this is a wet neovascular AMD or an exudative type of AMD, and this is bleeding that occurred in the choroidal level. You can see some greenish color, that is a neovascular membrane, choroidal neovascular membrane, which bleed into the submacular area, leading on to this patient will have a very poor vision, and patient may have a history of sudden loss of vision. Again, this is most probably after intravitreal injection of anti-vascular endothelial growth factor. And this is another very important topic for MBBS students. This can be asked, that is a retinitis pigmentosa. This can be asked as a short note or draw the fundus picture of retinitis pigmentosa. Okay, so what is retinitis pigmentosa? Retinitis pigmentosa, it is a retinal degeneration that affects the retinal rods initially or photoreceptors. First, the rods are affected and later on the cones. Rods are responsible for our night vision. So in the initial stages of retinitis pigmentosa, when the rods are only affected, patient will have defective night vision or nyctalopia, otherwise called defective night vision is otherwise called as a nyctalopia. If the cones are affected, then the day vision also affected. So the retinitis pigmentosa is a degeneration that affects the rods first, Inheritance. It is usually a patient gives history of night blindness in the family members. It can occur either as a sporadic case, that is without any family history, or it can occur as an autosomal dominant, autosomal recessive, or an X-linked type. All the types of inheritance, either sporadic or all the types of inheritance. The diagnosis, how will you arrive at a diagnosis of retinitis pigmentosa? We describe the classical triad of retinal arterial attenuation. You cannot see only the blood vessel which is seen as a retinal vein. That is, arteries are attenuated. Attenuated means invisible. Arteries are invisible, and you can see the bone spicule-like pigmentation. And when you see the disc, you can see there is a yellowish waxy pallor of the optic disc. So this is how the normal disc looks like. So this is how the normal disc looks like. But in this, you can see it is almost a yellowish white in color. That is the yellowish waxy pallor typical of retinitis pigmentosa. So the symptoms usually starts as night blindness in the third decade, and later it can lead on to a tubular field. Compared to the glaucoma, advanced stages of glaucoma, which again lead on to tubular field, this produces central tubular field. That is, retinitis pigmentosa advanced cases produces central tubular field, while the primary open-angle glaucoma produces a temporal island of vision or temporal tubular field, and later complete blindness in retinitis pigmentosa. So signs, I told you, the yellowish waxy, the classical triad, that is a yellowish waxy pallor of the optic disc with a bone corpuscle-like pigmentation and extremely attenuated thread-like retinal arteries or retinal, all the vessels, even the veins are also narrowed. And other features like a posterior complicated cataract or posterior cortical complicated cataract. So one cause for a complicated cataract is a retinitis pigmentosa. Other common causes include anterior uveitis. Other causes include high myopia, retinitis pigmentosa, etc. So what investigation help you to diagnose retinitis pigmentosa? In the initial stages, even before the appearance of the classical triad, you can get a electroretinogram and EOG, which is subnormal or extinguished in the early stages, even before the symptoms or the signs develop. And the patient, before developing the typical night blindness, patient says there is an increase in the dark adaptation. That is, patient finds it difficult to adjust to the dark when patient comes from light to the dark, especially in the evening, or when we go to a dark room from a well-lighted room. The normal person, compared to a normal person, they take long duration to adjust to that. That is called a defective dark adaptation. And in the initial stages, there is a partial or complete annular or ring scotoma. This is a spelling mistake. That is a mid-peripheral partial or complete annular or ring scotoma. So the treatment is, there is no treatment available. Vitamin A supplementation can retard the progression, but no much effect in the treatment. The only treatment is genetic counseling, and there are so many investigations are going on regarding gene therapy in retinitis pigmentosa. So the counseling of, because of the autosomal recessive inheritance, if a family member consanguineous marriage may predispose to retinitis pigmentosa. So this is again another picture which shows the classical triad of yellowish waxy pallor, attenuation of both arteries and veins, and you can see the blood, bone corpuscle like pigments. So if you have asked about draw the fundus picture of retinitis pigmentosa, which is a very common question, you have to draw a large round depicting the fundus and a small vertically oval disc. You can use a 25 paise coin for drawing the disc. And you can stain with a yellow pencil and mark it as a yellowish waxy pallor. You can draw red colored blood vessel as a thin one and mark it as attenuation of the blood vessels. And you can see black color. You can draw black colored spidery or bone corpuscle like picture and mark it as a bone corpuscle. So this is the classical triad. And I told you initially there is a mid-peripheral scotoma also in the peripheral scotoma, and this scotoma will coalesce together and produce a small central island of vision. And in the later life, this also will be abolished and the patient becomes blind. This is another very small topic that is maybe useful for your entrance. A cherry red spot. The most common cause for cherry red spot is Berlin's edema or trauma. That is a blunt trauma. Then I already showed in the previous class the central retinal artery occlusion with a cherry red spot. Other causes include glycogen storage diseases, Tay-Sachs disease, Niemann-Pick's disease, and Sandoff's disease. Okay. Okay, so that is the end of this small topic, of which important one for your theory exam is retinitis, mainly retinitis pigmentosa in today's class, and all other small topics, retinopathy of prematurity, PHPV or persistent fetal vasculature, all you can get questions of, like rubeosis iris, neovascular glaucoma, vitreous hemorrhage, recurrent causes of vitreous hemorrhage, like that. ARMD also during your practical exams, causes for non-improvement of vision after cataract surgery. So only one more class is remaining, that is mainly on retinal detachment and vitreous hemorrhage. So I will be dealing with that very important topic tomorrow. Any doubt? Anybody? So
No, ma'am.
shall I stop?
Okay, ma'am.
Okay.
Thank you, ma'am.